All right, well, good morning, everybody. Thank you for taking the time to join us on a beautiful fall morning, and I want to just extend another word of gratitude to the organizers as well for including me and for their collaboration on this team. It's really when people ask me why I've stayed here for as long as I have, I've been here since I did my training, I tell them it's the people, and the people who work together to hopefully help folks like you. So let me just jump into this. So you've heard a lot about left ventricular outflow tract or LVOT obstruction already, so I won't stress this too much. This was actually a figure that Dr. Madrazo already showed us. And the main issue that we address with alcohol septal ablation is the bulging heart muscle tissue that is abnormal, that is contributing to the obstruction with that abnormal interaction with the mitral valve, as eloquently described by Dr. Gammy just now. And so here's just another figure that shows you what a normal heart looks like, and here's a very dramatic example of HOCM. So about 70% of HCM patients will have LVOT obstruction with resultant symptoms. And medical therapy is really the mainstay, but as have heard, there are some patients for whom medical therapy will be insufficient to achieve adequate symptomatic relief, or sometimes the tolerance of those medications can be challenging. And so septal reduction therapy is then considered an appropriate course of action. And in general, I think the overall bias, if you go to most HCM centers, is if somebody can get a myectomy, that might be the best procedure because you'll be able to get as much of the tissue out safely as possible to fully alleviate the obstruction and treat those associated findings, whether it be a elongated mitral valve or those abnormal papillary muscles, treat the mitral valve if there's regurgitation, treat the atrial fibrillation. But obviously there are some cases where surgery may not be in the cards. And sometimes, there are cases where people just have a preference not to have open heart surgery. So again, we talked a little bit about, you heard a lot about myectomy just now and what comes with it. So alcohol septal ablation is a catheter-based, minimally invasive approach to try to address this problem from a different angle. And so in a sense, if Dr. Barth is the heart's electrician, I'm the heart's plumber. So we come in with a plastic tube through a needle puncture of one of your blood vessels, usually either in the wrist here or in the leg right where it meets your torso in the groin. And we put a tube that goes all the way to the heart, and we can enter the arteries that feed the heart muscle. And that's a pretty standard technique that we use for diagnostic purposes or to treat people with heart attacks, for example. And what we do is we actually go into the blood vessel that feeds the abnormal bulge that's causing the LV outflow tract obstruction. And if we can, and that's contingent upon us actually finding a vessel that feeds the right area. And then what we do is we put a smaller plastic tube or catheter that has a little balloon at the end. We can inflate that balloon, and then anything we inject through that balloon catheter just goes to that area. It won't go to any other area of your heart muscle. And then what we can do is we actually give a type of dye that we can see with ultrasound. And when we do these procedures, we have either Dr. Carrick or Dr. Madrazo or one of our other imaging experts with expertise with HCM, as well as one of our sonographers. And we actually look and see, are we targeting the bulge? Is this blood vessel that we see on our x-ray pictures that we use actually going to hit the area of tissue that is causing the problem? And if it does, then what we do is actually inject absolute alcohol, 200 proof, to induce a limited controlled myocardial infarction or a heart attack. We basically want to kill off that area of tissue as opposed to cut it out so that it can no longer cause that obstruction. So again, catheter-based minimally invasive procedure. So in contrast to a septal myectomy, where you need to have open heart surgery, we don't need to open the chest. We don't need to use a heart-lung machine, and we don't need to put you completely to sleep, but we do use what's called deep sedation because obviously if your heart muscle is dying, it doesn't feel very good. So people are deeply sedated so you don't feel this. But as a result, it's less invasive, which means a shorter, easier recovery. It's usually a couple of days in the hospital and about a week or so before you can go to full unrestricted activity. So here's an example of the x-ray pictures we take of the blood flow to the arteries that feed your heart muscle. So here we're actually looking at this little branch that comes down this way, and that is going into the proximal septum. That's where the bulging tissue is. So this is actually a good target. We can actually see, to the trained eye, I can actually see there's compression of this tissue by the pattern of the dye flowing in here. So I know this is going to be a good target. And then here we've put a very tiny little, what we call guide wire, through to get ourselves into that branch. And then we've delivered this little balloon catheter, and we inflated it with a combination of salt water and dye so we can actually see it inflated. And now it's blocking any blood flow into the branch vessel, and then anything we inject downstream is going to stay down there. Okay, so now we're looking at the echo. So here is the bulge area here that we're going to be targeting. And then what we're going to do, and then I'll show you. So that's the bulge, and this is what it looks like when we actually look at the pressures inside the heart and then in the water main vessel called the aorta. And without going to too much detail here, I'll just show you that these big spikes versus this squiggly line down here, that's abnormal. These two lines with each heartbeat should be pretty much overlapped. But you can see you have these big peaks, these big almost mountains going above this other line down here. This other line is the blood pressure in the aorta, and these big peaks are the blood pressure in the pumping chamber behind the area of obstruction. So the bigger these peaks, the more the obstruction. And so you can see this big area of obstruction after an extra heartbeat because we decrease the volume of blood filling the heart, and that's very classic. This is actually diagnostic of LV outflow tract obstruction in a patient with HCM. So we look at this pre, and now we've mapped the area with this, what we call echo contrast, or basically dye that we can see with the ultrasound. And you can see this area lights up right here where the obstruction was occurring. And we don't see any area otherwise in the pumping chamber lighting up. So this is a good target, and this is a situation where we feel confident that we can get a good result by injecting the alcohol. So then we go ahead with the alcohol. So this is what it looks like after. You can see there's less flow into this branch. And now you can see that those peaks are much smaller, but they're not entirely gone. So that's the one downside of alcohol septal ablation, I would say, or one of the downsides, I would say, compared to septal myectomy, is that we won't get as complete reduction in the gradients. That is, we won't reduce the obstruction or get rid of it completely or as completely as you might with a good myectomy. But particularly for a patient for whom surgery may not be a good option, maybe because of age or other health problems, this could yield excellent symptomatic relief. That is, relieving the shortness of breath and other symptoms you may have and help you to feel better. And the outcomes are excellent, and they're durable over time. So this is just a graph showing patients who have undergone a septal ablation and how long, going out to 15 years. You're going to see that probably more than 80% are going to go on without having any other issues with their heart related to their HCM. And then in a review of over 4,000 patients over about an average of 7 years, comparing, not in a kind of randomized way, these are observational data, these are observational studies. So obviously patients were referred for one procedure or another for specific reasons, and that can impact the outcome. So we got to keep that as a grain of salt. But in terms of risk of dying, there's actually a lower procedural risk with a septal ablation compared to open heart surgery, maybe a slightly lower risk of stroke. The one thing that is definitely higher with a septal ablation is developing the need for a permanent pacemaker. That's because your heart's electrical system has important fibers that run right through that area of bulging tissue. And when Dr. Gammey's going in there, he can be very careful in terms of shaving the tissue and ideally avoid getting into that. But when we inject alcohol, we can't tell exactly where that alcohol goes, and we may knock out some of those fibers. And in 10% of cases, if you don't already have a pacemaker, you end up needing a pacemaker, whereas it's about half that for a septal myectomy. And then again, because we can't necessarily, we may not be quite as effective as reducing the degree of obstruction, there may be a need for further procedures, either another septal ablation or potentially going on to a myectomy. That happens more with a septal ablation than, say, somebody who's had surgery initially. So you can see that's about 12% in these studies who have had septal ablation compared to about 1.5% for the patients who had myectomy. So usually a myectomy is a more definitive procedure. So what are the considerations in terms of thinking about which patient should have a septal ablation, which patient should have myectomy? So we want to know about the septal vascular anatomy. That is, the blood. We have to start with the blood vessels. If there's not a good blood vessel going to that territory, or that blood vessel that we think might be good doesn't actually supply the area we want it to supply, or it supplies other areas that would be bystander, that we don't want to kill off, then that would not be a good option for that patient. The septal thickness. So if the septal thickness is more than 3 centimeters or 30 millimeters, so that's over an inch and a quarter or so, then we're not going to be able to reduce that down enough to get a good result, and you're going to be better off having a myectomy. Certainly, as Dr. Gammy suggested, if there are issues separately with the mitral and papillary muscle anatomy, which can occur frequently in patients with HCM, then this technique may not be as good because we're only targeting that septal bulge. If there's pre-existing untreated electrical system disease, particularly if somebody has something called a right bundle branch block, we're likely to knock out the left bundle branch and cause the need for a pacemaker. So maybe in those cases, we might favor surgery as well. Again, less reduction of the degree of obstruction measured by gradients. And there's always been this theoretical risk of what we call ventricular arrhythmias, so abnormal heart rhythms caused by inducing the heart attack. We know people who come in with natural heart attacks, so to speak, are at higher risk for arrhythmias. We haven't quite observed that in the patients with, who undergo septal ablation, but it's always something in the back of our minds. That's why we keep people in the hospital for a couple of days for monitoring of the heart rhythm. So certainly if you have existing conduction disease, maybe depending on the type, you're better off having surgery. If you have issues with the mitral valve, the papillary muscles, certainly if you're at a high volume center with an experienced surgeon like Dr. Gammy, then we probably will lean more to myectomy as the first line treatment. You think about risk of perioperative complications, particularly with open heart surgery, and certainly if you have other health issues that contribute to the risk of having a serious complication with surgery, that might bias us towards an ablation. And I think that's it. I will stop there. Thank you.